Hi there, it's Lisa Schumann coming back with another episode of Donor Conception Conversations. And today we're going to talk to Dr. Frederick Licciardi, who's going to talk to us about a lot of things that you'll find very interesting with regard to egg donation. In previous episodes, we've talked a little bit about donor conception and screening, genetic screening, PGT screening, ways to think about screening and whether you should or should not use it. And today he's going to dive deeper into what it means to screen, why it's important, how to think about choosing your donor, how to think about how donors are screened, and all kinds of important information that I think you will find very valuable. So come and enjoy us, pull up a chair, and let's get started. Welcome to Donor Conception Conversations. This is the one podcast created exclusively for people who are planning to build their family with donor conception or have donor-conceived children. I'm your host, Lisa Schumann. I'm a researcher, an author, and a therapist, and I'm passionate about donor conception and helping people have a better path to parenthood. And today, I am very fortunate to have Dr. Frederick Licciardi here to talk to us about lots of things about donor conception. And before we do, I'd like you to listen to something.
And if I make it back alive, I'm gonna take a wife. I'm gonna live my life with Nikki Joe. I'm gonna walk that line, give her all my time, leave my past behind with Nikki Joe.
And that, everyone, was Dr. Licciardi's other talent, which is he's a fantastic musician. You can find him on Spotify and see what I'm talking about. He has beautiful, wonderful music that is really touching to me and very moving and musically incredible. So check it out. But first, I just want to mention that Dr. Licciardi is a professor in the Department of Obstetrics and Gynecology at NYU Langone Fertility Center, which is also part of the Prelude Network. He is a practicing reproductive endocrinologist, where he's also director of the fellowship program of reproductive endocrinology. He has numerous clinical articles that have been published in the Journal of Assisted Reproduction and Genetics, Obstetrics and Gynecology, Fertility and Sterility, which is kind of our Bible, and Reproductive Endocrinology. He has been recognized by the American Fertility Association for his dedication to his treatment of infertile patients, and he's the author of an award-winning infertility blog. He served on the board also as of the Society of Assisted Reproductive Technologies, just to name a few of his shining achievements and his decades of amazing work. So I would like to just let the audience know that Dr. Licciardi has been around for decades, and he's an amazing doctor. And when I saw his presentation at the donor egg meeting where we both presented, I was really amazed by some of this information, which I'm sure you'll be really interested in hearing about too. So welcome, Dr. Licciardi. Thank you so much for coming.
Well, thank you very much. I mean, very nice introduction. Thank you very much. It's really nice to be here. I'm really looking forward to speaking to your group. I love giving information. You know, when I see patients, I give them my email address directly. I just hand it to them.
Wow.
And I tell them all. I say, listen, I don't care if you email me twice a day. I don't. And people think I'm joking because giving people information just gives them so much, power, and it gives them a way to think on a rational level, it's really nice. And it's a little bit selfish on my part. I tell them, listen, it's a little selfish because I don't like my patients to be upset. My life is easier if your life is easier. So it's just a really nice practice. I'm really grateful for all of my patients. And thank you for touching on my music. It's really is a compliment because as an artist, medicine is it's not artistic. I mean, they always talk about medicine being an art, more of an art than a science. And I don't like when people say that because really it is a science. And then the more science you know and you understand in medicine, actually, the better doctor you are. That's how I believe it. But I got really inspired by, we had a lecture at NYU a number of years ago, and a man came in who used to be an orthopedic spine surgeon, and he converted to a photographer. And the one thing that struck out in my mind, he says, as a photographer, you can make a mistake. And as a doctor, you can't. And he says, actually, a lot of your mistakes turn out to be really good things in art. And in medicine, that doesn't happen. So I joke with
Mm.
my wife sometimes because I go downstairs in the basement and I write songs. She goes, "Where are you going?" I said, "I'm going to go make some mistakes."
That's great.
Yeah, and then it turns into a really nice thing. So anyway, thanks for having me.
That's wonderful. Well, thank you for sharing that. And I hope everyone goes to Spotify and checks out your music because it's really terrific. So for today, I was curious about your thoughts about this yes or no with genetic screening. And of course, lots of people say yes, other people say no. Some people say, well, the patient has to decide. And we've had, all sorts of different opinions.
Yeah,
And I was really interested in your talk because you brought up some really important points for people to understand, I think.
it's a very important topic, but I think at the same time, it's a topic that doesn't really get much thought. So what I mean by that, so let's just go into some of the history. Preimplantation genetic diagnosis, there's always been controversy about its value in young patients and old patients, donor. Are you getting the right results? Is it accurate? Is there damage to your embryo? There's pros and cons. And does it increase your chance of actually having a baby? Does it improve your overall take-home baby rate? I mean, that's really what it's all about, right? So, we published a number of years ago. We were the first ones to publish on the outcome of preimplantation genetic testing in a donor egg, specifically in a donor egg cycle. And we looked at those patients who did and those patients who didn't, and we had like a large series. It was 400 patients in total in all of our groups, and we found that the outcome, the baby rate, was no different if you did pre-implantation genetic testing or not. So that actually raises some questions, because if you look at donors who undergo the testing, like recipients who ask those embryos to be tested, at least 30% of the embryos that are tested come back abnormal. And it could be 40 or 50%, depending
Hmm.
on the lab. Some new information there we can talk about. So how could it be that we know we're weeding out a good proportion of bad embryos? These are embryos that have extra chromosomes, missing chromosomes, Down syndrome, and the like. And if we know we're weeding those out, how come we're not upping our game? How come we're not offering the patients who do the testing a higher delivery rate? It doesn't really make sense, and it still doesn't make sense. So the possible places to point are, well, when you do embryo testing, it is rather invasive. We have this beautiful 100-cell embryo, and we're going to really be aggressive with it. We're going to take a laser, we're going to open up the shell, we're going to take a grasper, we're going to go in there and pluck off 5 of those cells. Now we're going to freeze the embryo, and that may have not otherwise happened. So others are certain steps. Plus, those cells have to be analyzed. In my lecture, I said, it's like finding these results, you might say, is like finding a needle in a haystack, but it's
Mm.
really even more complicated than that. It's like finding a needle in the universe. It's
Wow.
really, we see this output, but what goes behind the scenes, as far as all these software programs and analytics and high level mathematics, including artificial intelligence now, that goes into analyzing this embryo, it gets better all the time, but there probably are some flaws along the way that we haven't recognized yet. So that's our study. There was a study before ours just looking at a much smaller group. We looked at single embryo transfers, which is very valuable because there's other factors that go into people getting pregnant or not. How many embryos are you putting in? So before us, there was a smaller study that showed the same thing. There was a study that looked at what's called the START data. So most IVF centers in the country have to report their data to a central location, which is overseen by the government. And that data is actually accessible to researchers. So someone went into that database, now thousands of cases, and same thing, reported that there was no difference in outcome if you're doing the testing or not.
Hmm.
So, and there have been other studies since and other similar studies which all point to the same thing. So that being said, where are we? So should it be done? Is it being done? Well, the fact is that the testing is being done in a large number, over 50% of cases of families that are doing egg donation, and they're testing their embryos. And I think there's reasons for it. And I think one of the main reasons is, listen, I've been infertile for X number of years. I'm spending X number of dollars to make this happen. And if you're telling me that there's an additional cost, which is not huge compared to everything else I'm spending, and you're telling me that there might be some abnormal embryos in there that I can weed out, then why wouldn't I do that?
Right.
I've been so fearful. I've already had miscarriages. I've already had failures.
Yes.
Why can't I just want to get that test done for peace of mind? Because if I don't do it and I have a problem, I just don't want to put myself in that position.
Right.
So I think the good news is that I don't think testing is harmful. Like, no one has shown that testing gives you a worse result. And you might reduce your miscarriage rate a little bit. Miscarriage rate's going to be low anyway because you're dealing with a young embryo. But if you're wondering what I tell my patients an abbreviated, version of this story. And I just say the data just shows you don't have to test. So my recommendation is not testing. I don't say you can't test, but I say, listen, you don't need, the data is very clear. You don't need it. But still, many, many patients go on to have the testing. Now, we didn't touch on this yet, but if you're going to use a gestational carrier, then I think it makes more sense to test, because now you're even spending more money. And now you have a logistical problem, right? You have this donor who's only available at this certain amount of time in a certain segment. And, you don't want to lose her, et cetera, et cetera. And even though I'm telling you it probably doesn't matter, even if there's a slight chance of a higher rate of miscarriage, or it's probably better to test, especially because you're going to hold on to these embryos long term. You might have to hold on to these embryos for 6 or 12 or 18 months before you transfer them.
Yeah.
And you might have some abnormals in there. It does happen. But if you're transferring them into yourself, we don't want this to happen. But if you're not pregnant, you can maybe get some more eggs and try again. Whereas if you're using a carrier, the schedule is so tight, it's very hard just to say, okay, hold on, I need a couple more months. I need to get some more eggs and embryos, and then I need to have you come back. She's going to find another person to get it. She should. That's her right. So if you're storing them for yourself or for a carrier, longer term, then I think it does make sense to test under those, more sense. I'm more strongly an advocate of testing in under those circumstances.
That's really interesting. And I think just to kind of back up for a moment, I think people also would be interested to hear with SART, it's not just available to doctors, it's available to patients. So anyone who's watching this can look up success rates on the CDC website, on the ASRM website. And Dr. Licciardi brought up a very good point. That's really valuable information to have too.
Yeah, if you go to the SART website, which is SART.org, and then you'll see find a clinic, that part's easy. However, it's really not that easy to assimilate the data. They do make it rather confusing, like hideously confusing, seriously. So if you do have a doctor, it's might be nice, or a counselor, to go on that with somebody else so they can kind of guide you through. There's different parts of the website, and they all have different rates, and they're all calculated different ways, and it is very, very confusing.
And a little bit behind the times.
And a little bit behind the times.
Yeah.
That's right.
But it's still there. So that's nice to know.
True.
Well, that's really helpful for people to understand. And thank you for that. And I think people will be relieved to hear that either way, they're not doing anything wrong. If they're testing or not testing, that they still have a very good chance with donor eggs of having a very successful pregnancy. What would you say about the take-home baby rate approximately with donor eggs is now?
You're still at about 50 to 60% per embryo that you put in. So you have to get the eggs and fertilize them, growing and everything. And that varies a little bit, because even though your doctor might tell you, hey, you have an embryo quality varies. Some embryos, even though an embryo might look good, it's possible it could look better or worse. So there's some sliding scale there based on just how many cells it has and how it's growing. There still is some clinic to clinic variation. You could find that on SART under the donor egg pages. But overall, compared to the pregnancy rate that most recipients are facing without donor egg, if they have eggs, first of all, some of them don't, but if they do have eggs and they're in their, mid 40s, and they're going to do in vitro and make 1 or 2 eggs at a time, their rate on their own might be anywhere from 5 to 10%. So it's literally an order of magnitude higher than it is if they were going to try on their own with their own eggs.
And I think that, everyone, right, everybody's evolution is different, where they can get to a place where they can use an egg donor. But certainly it is reassuring to know that the success rates are so much higher. And also you have a better chance of having a healthy baby, right? So it's so nice for people to have this option. And what about the donors that you've seen? You've seen so many donors, probably thousands over all of the years. What would you say makes a good donor? And what should people be looking for?
It's a great question. And the answer is I think the answer is a lot more simple than most people take it out to be. So what's a good donor? So donors, first of all, every single donor in the country has to fulfill a minimal screening requirement. And this is dictated by the federal government. Egg donation is actually a device. So it's regulated under the FDA. So the FDA will come into my office and do an inspection. Oh my God, talk about stress, but we always do well. So what is that? That's HIV, hepatitis, those are the infectious diseases, right? So that's one part. The other part is the age of the donor, right? Most donors are under 32, 33 years of age. It's interesting in that we would really like to use donors who are 34 or 35 because their outcome is still really, really good. But for a lot of recipients, it's hard to take a donor who's 35 because you may not be much older than that person, even though she might have a ton of eggs at 35. So most programs keep it 32, 31 and under.
Mm-hmm.
So there you go. So that's a checkbox, right? And then you want to have a donor who is going to make eggs, but that actually should be, and your clinic should talk to you about that. That should be screened out by the doctors because the doctors don't want to give you a donor that doesn't make a lot of eggs. They don't want you to be upset. They're worried about their pregnancy. They want you to be happy. But there might be some variation. And the way you analyze that, the way that's analyzed is 2 methods. One is what's called an antral follicle count. So this is an ultrasound that's performed to literally count up the eggs. Now, we can't count up all the eggs, but the ones that we see are the ones that we can get. These are the ones that are more mature. So a donor typically has an antral follicle count of around 20, meaning when we do her retrieval after drug stimulation in vitro, we're expecting to get about 20 eggs. And that could vary from 15 to 25 to 12 or whatever it is. So you should know that when you talk to her, hey, what's this dot? What was her antral follicle? Is she going to produce eggs? So that's important. Other things which you can't always go by, but history. Did this donor come through before? How was her egg production? How was her embryo production? Was there a child born? And you may or may not be able to get that information. We used to call this the proven donor. Has she been successful before? On that, I tell my patients, listen, it's not always easy to find a donor. And if you find a donor that you really think is the one, like really outstanding compared to the other ones that you've, evaluated, and she's not proven, and this is her first time, I would still use her because she seems important to you. And, the chance of a donor being a dud, so to speak, is like 5%. So just go with her odds. You're going to be fine. And if really this is the donor that you want, if you're more loose about your requirements, like they all seem good to me, or this one, these two are equal, then it might be nice to go with the one that's been proven. But if you really like her, I would choose her either way. All right, so that's that. And then there's the more specific choices, height, weight. Many organizations, many agencies might offer you an SAT score or some sort of college transcript. We never did that at NYU, actually. And I would tell my patients, listen, you just really need to know what she's doing, her accomplished. Like, what is she doing? Does she have goals? Is she directed? Is she successful in what she's doing? And if that's the case, then those other tests probably they're not really helpful. Not everyone who has a good SAT score is successful or driven, et cetera. But those are choices that you can make. I understand that. I like to bring in the story that I talk about, and then I say, listen, the women, the couples, the people who are more lax in a good way with choosing very specific donor criteria. I said, you should take a lesson from the women who already have children, because the women who come in to do donor egg, who already have children, the vast majority of them, you start talking about characteristics, they're like, I don't even need to hear it. They're like, don't worry, I'll take care of the characteristics. That's my job. Just get me an egg. I'll take care of the rest. They are very confident. They are very knowledgeable. They are very aware about the nature versus the nurture. And of course, the nature is going to have a little, we can't rule out everything. But I tell that to my couples who are struggling with all these details, who have never been pregnant. And I think it helps them. I think they kind of say, look, and I always tell people, you're picking your donor. You're not picking your baby. You are not picking your baby. You're picking, some of the genetic contributor, some of it.
Yes.
To your baby. And look at the families around you. Are siblings different from one another? Are kids different than their parents? There's similarities, of course, but maybe not as many as you think they are. And then the other thing, is people want to get it. I always find this funny. I love it when women come in with their babies who have done donor egg. And in most cases, the recipient will say he or she looks like me. Or someone will tell them who doesn't know they did donor, whatever, oh, looks just like you.
Right.
And what's going on there, I don't think it's because they picked, their doppelganger, whatever it's called. I think it's because there's probably 1,000 facial features, right? And all you have to do is have one of them and you're a lookalike.
Exactly.
So maybe the nose is a little bit like yours, looks just like you. Maybe the eyebrows are a little bit like yours, looks just like you. The mouth, the lips, whatever. They pick out, all you have to do is find one thing and you're a dead ringer.
Right. Exactly.
So I find a lot of joy in that, because the moms are really like, they feel like, they're a little relieved, like when they hear that.
Yeah.
So anyway, that just getting back to how specific and detailed you need to be, on making, this choice. Listen, everyone's entitled to make their own choice, but it's nice if we can help you at least reduce some of your stress associated with these choices.
Talking about that, I think, like we're talking about what makes people comfortable, right? Is this person look like me? Is this person somebody that I like? And as you said, you're not picking your child, you're picking your donor. But what about all of the other factors? Is this person, young enough? Are they healthy enough? Is their family healthy enough? I mean, you're already picking from a very good pool because they've already been pre-screened, right? And so they're picking from a good pool already, but how do people kind of weigh that?
So I tell people, listen, you're in the donor egg business now, and being in the donor egg business means that you have to accept some uncertainty. Listen, this is the truth. If you think that every single donor who's ever donated has been 100% truthful in her application, then it's just not the case. And we know that.
Yeah.
So what can we do? We can screen. I tell people a huge red flag to us is consistency. All right. Because that donor is not just meeting Dr. Licciardi. That donor is meeting an assistant, a front desk person. She's meeting a number of nurses, coordinators. She's meeting a whole team, the psychologist, right? So we hear the stories. She's telling one person one thing and somebody else another thing. We know that. And that is just, you're out the door, right? That's a huge red flag. And I do tell people, listen, I've seen so many donors. I said, I just have to tell you, they're just very sincere people. They're very kind people. When my daughter went to NYU 10 years ago, I calculated that $10,000 paid for about 8 weeks of her being there. And now it's probably 6, right? With inflation. Right. So I said, no one's getting rich on donate. They're not going to buy a fur coat and a Ferrari. They're going to maybe pay some bills. So the point is, if money were the driving factor of a donor. And I do say, listen, if they weren't getting paid, they would be much less likely to do it. Okay, that I get. But if you think money is the driving factor, we wouldn't have waiting lists. We would have donors lining up around the block to try to get in here to get this cash payment. It's taxable income.
Yeah.
So I just have been privileged, really, and honored to have these women come into my office who want to help somebody. It's not easy for them. They're taking 2 weeks of drugs. They're getting side effects. They're having anesthesia, getting put to sleep. I mean, come on.
Yeah, absolutely.
It's really unbelievable what they do. So you're getting an amazing person. Is there this woman who's just like, we've all heard the stories, and I'm not going to deny them. There are probably some donors out there that have donated 20 times. They move from clinic to clinic, they cash in, they move on, they cash in, they move on, they cash in, they move on. It's probably true.
Yeah.
But maybe they're nice people.
Right. Yep. And maybe they're nice people anyway. And before they get to the process where they can donate, can you explain what they go through in order to be screened? Because I'm sure there's probably many donors you see who you say, gosh, she's a lovely girl. I wish I could pass her, but I can't.
So the screening. All right. So it starts with an application. This is pretty similar for most clinics. For every application, if you get 10 applications, maybe you get one donor out of that. So just screening on the application is really important. And what are we looking for? We're looking for age. We're looking for reproductive history. We're looking for health history. We're looking for psychiatric history, medications, all those things. So when we see an application that we like, we invite the donor in. So she'll have an interview. She'll have this basic testing, the HIV stuff, make sure she has eggs. Then she'll have an interview with our psychologist. And she'll take the MMPI. So she'll take a written psychological evaluation, which isn't that easy to fake, actually.
Right.
So that's that. We want to make sure her height and her weight are okay, standard stuff. And then once that's all good to go, providing she passes, and of the people who come in to see us, about half of those end up being donors. Wow. So some of them don't pass the screening. Some of them change their mind. Being a donor screener, as when I was the director of the program, was a very, very frustrating operation because you're spinning your wheels a lot. You're taking a lot of people in and you're not getting a lot of people through. So a lot of just on that, just so the recipients understand, a lot of that is happening on their behalf. So that's it. And that's the screening and away we go. Not only do we do this genetic screen where we're checking them for 500 genetic diseases, a genetic counselor is also speaking to them because there's a lot more diseases out there than 500.
Yes. And
so there's a lot of information just in that family tree, going back to the grandparents and the nieces and the nephews. You find a lot of things in that tree that a lot of times the genetic testing was normal, but the tree was not adequate. And so they are not included.
Well, I think that's really helpful for everyone to hear because when they see the donor pool, you're already kind of getting the cream of the crop. There's been such an attrition in getting to that place. So those are really the people who are the healthiest, who probably could produce the best eggs, who are most likely to produce a good amount of eggs and are probably really solid genetically.
Exactly right.
Yeah. And that can be hard, I think, particularly in the known donor situations where people say, well, I have this best friend or I have this cousin and I'd really like to use them for an egg donor. And is it tough for you being in the situation where well, our egg donors can give these people, a better chance, higher chance for successful pregnancy, healthier baby than this friend whom they may like very much, but maybe the friend's older or has genetic difficulties or has, mental illness or serious, significant health issues in their family.
It is tricky. So the first thing I tell people is the biggest, and it's hard to hear this until you're deep in, but number one, and you've heard at the same lectures we've been to, you've heard the lawyers say, the number one source for litigation in a donor situation is a family member. Family members are more likely to sue than non-family members.
Yeah.
or known acquaintances. So it's a problem. However, it can work out. But it's all about getting informed. In other words, this friend of yours is going to go through the same screening, especially on the psychological side, and things are going to come up. And as long as it's disclosed to you, and then you can decide if you want to, have that person donate to you or not. On the psychological side, it's not just she meets with the psychologist. It's you meet with the psychologist with her at the same time. You're all in the same room. You're all talking about things you never wanted to talk about. But it's really important for these things to surface initially in the beginning. So, those situations are doable, but they more often than not start with best intentions. And then for some reason, they just fizzle away. Like, especially on the sperm donor side, so many women come in and say, I have a friend who wants to donate sperm. And I'm not mean about it, but I'm really not. But I have so much experience where this has worked out 0 times in my practice, 0. I just say, listen, you're welcome to do it. But in my experience, by the time you get to the lawyers and the contracts and figure out all that stuff, it's not worth it. Everyone who's come in telling me that story uses an anonymous donor. But if you want, maybe 1 or 2 exceptions. So if you want to start down that road, it's fine with me. But I can tell you, it may just be a waste of time. So you let me know.
There's so many potential problems, and it's so complicated, right, to have a known donor. So I think it's really helpful to kind of think through these things. And of course, people have good intentions. They think, oh, well, this will work out beautifully. But, even in marriages, not all marriages work out. So it's hard to kind of think about that when you're in the middle of it. But this is really helpful information. Thank you so much, Dr. Licciardi. Are there any other things that you think our audience should know about donor conception that we haven't touched on yet?
The people who do it is amazing how happy they are.
Nice.
First of all, there's so many reasons. These kids turn out to be like superstars. Why? Because they have amazing parents or an amazing parent. Why is that parent amazing? Because she's older, because the couple's older. Makes a huge difference in raising. You have your own personal life. You have your own business interactions, right? You know how to deal with people. You know how not to sweat the stupid little things. You know how to focus on what's important. And that just shows in the way that these kids are raised. It's unbelievable. They're wanted, but beyond, obviously, parents get tortured to have these kids.
Yeah.
So that's there. But it's not for everybody, right? This is a select group. These are people who came to me saying, this is what I want to do. I have a lot of infertility patients who are in their 40s who haven't gotten pregnant on their own. We talk about donor egg. They say, I don't want to do that. That's okay. It's not for everybody.
Right.
But for those people who are like, there's certain things about, being a parent of a donor egg that's making me a little bit nervous. You should talk to people who have done it and see the beauty of what's happening here. I mean, you're building a family. It's unbelievable. Again, it's not for everybody, but the end result it's actually very difficult to describe how wonderful it is.
That's so nice.
For those of you listening today, I don't only do donor egg. I do all sorts of infertility. So you're welcome to see me for whatever you'd like to see. And if you would like to find me on Spotify, it's new. So you have to specifically type in just Fred Licciardi together, and then it'll pop up because it's the algorithms are still trying to find me. But I do appreciate the opportunity to talk about that. So thank you.
Oh, it's my pleasure. And my pleasure to have you here. And thank you for all your information and the encouragement. I think it's such a hard time for people to kind of get through this process, and to hear those words that it turns out beautiful and you're going to have a beautiful family is really so nice, and a beautiful place for us to end on. So thank you so much. And can people find you through NYU Langone Prelude, or how do they find you?
If you just put in Frederick Licciardi or Fred Licciardi or Dr. Licciardi, that, my medical stuff pops up right away. You'll find me right away.
Okay, terrific. All right. And for everyone out there, thanks for coming today. And please subscribe, because that's how we keep going. And that's how you'll learn about all our new episodes. So thanks very much. And I'll see you next time.
Thank you.
Since meeting each other and forming Empower, we've just been really focused on understanding the landscape of embryo donation and understanding what the patient needs are for donors and for recipients. And we've done a lot of research around it too. And I know you're very evidence-based, Lisa, and you've kind of stay grounded